some discussion and questions. So this project was funded by a grant from the Canadian Institutes of Health Research, CIHR, through their strategy for patient-oriented research. And I'd like to acknowledge we also had contributions from the University of Victoria, from our Island Health, our Regional Health Authority, and the Victoria Division of Family Practice. And so the main purpose of this project was to define culturally safe primary care for people who use substances. And we used a patient-oriented, or what we call a community-based participatory model of research. So we'll be talking about both of those things today. Want to advance the slides?
Oh, I do.
Thanks.
Okay. It's a team here.
Yeah.
Okay. There we go. We'll give it to you all at once. There we go.
There we go. All right. So shifting from researcher-driven research to patient-driven research is central to what the strategy for patient-oriented research is trying to do. And so we'll refer to that strategy as SPORE. It's an ugly acronym, but it works and it's faster. So we were always aware that when you make that shift from researcher-driven to patient-driven work, including patients on a research team can be tokenizing, as well as isolating and even potentially harmful to people. If patient-oriented research is to be done collaboratively, if it's meant to build a more accessible, sustainable, and equitable healthcare system, which is ostensibly what we're trying to do, then it has to be centered around patients and specifically their community and their context. So using, so we say that we shifted not just to patient-driven research, but then to community-driven research. And using CBPR as a method for patient-oriented research means that we're really putting the experience of the community at the heart of the research and bringing together people from the community with academic and health policy partners. CBPR has a long history, as many of you may know, within health research, and it's really about involving the community from the beginning stages of the research project and having them involved throughout. And also having the research link specifically to action. So action around improving health outcomes. So we're getting a little bit of an echo. Oh, it's gone. That's good. That might have just been a pickup from another mic. So with that, next.
Sorry.
You should be able to just do your arrow.
The assistant is slow.
It's okay. It's Monday. We're having a nice slow start to our week. So I wanted to touch upon a little bit of how we went about doing this, our approach overall. This is our fancy diagram. We convened this full project team after we had an introductory meeting, and that was initiated through our health authority originally with the Victoria Division of Family Practice, and researchers at Royal Roads, and where we are at the Canadian Institute for Substance Use Research at the University of Victoria. So we took that full first year to really just get to know each other, to land on a topic that we could all get behind by bringing in all these different partners from our local community. So across all of the organizations represented, which did eventually include the Solid Outreach, as well as Umbrella and the BC Support Unit, there was agreement across all of our partners that the issue of stigma and the role that it plays in help seeking for primary care was really key, and it really needed some attention. So to tackle this issue then, we needed to have a guiding framework that was going to help us to figure out how we wanted to explore the issue of stigma.
So the framework that we chose is the framework of cultural safety, and cultural safety is probably fairly familiar to most people in British Columbia because it has been very much promoted to address stigma, discrimination, and racism in the healthcare system. It originated in New Zealand to address unmet healthcare needs and systemic racism racism impacting the health and healthcare of Maori people. And as I just said, it's been taken up very widely, not just across BC, but actually across Canada and internationally in relation to Indigenous peoples. But some scholars have said it also could be applied in other situations of stigma and discrimination. And so we were looking at it in the context of stigma related to substance use. And I think the really critical thing to remember is that whether or not a healthcare service is culturally safe is defined by those who use the service. So it doesn't matter what I, Bernie, think I do in terms of providing culturally safe care. I may perceive that I do a very good job, but it's how it's perceived by those receiving services. So it requires, as healthcare providers, that we reflect on our own positionality, our own privilege, and also that we have a broader understanding of how conditions in society affect people who are coming to receive care. Part of the reason that we chose cultural safety as our guiding framework for this work was because we had already completed a project around completing culturally safe care in hospitals. This is a project that was actually done with Solid outreach from 2012 to 2015, where we asked people who were in hospital what they actually thought was culturally safe care in hospital. And we asked people who had been using substances and experiencing some other combination of structural disadvantages. And so the picture you see there is of the Solid advisory team who were basically oversaw and guided this project and the development of the little handout you see there. So we knew that cultural safety would be a viable framework for this work. So we have a couple of objectives for the Creating Culturally Safe Primary Care study. And one of them was to identify ways of creating safe spaces for service planning, implementation, and research that are inclusive of population who use substances, investigate patient understandings of culturally safe care and primary care, and then develop recommendations for implementing culturally safe primary care and for doing research as well, because we felt that we couldn't do a project on creating culturally safe primary care without doing research that was also culturally safe. So when we share with you the findings, we're going to share with you what people told us culturally safe care means to them in primary care, and then we'll end with talking about a little bit about culturally safe research. So I'm going to turn it over to Paige, and she's going to talk a little bit about the project expectations, because it was really important at the beginning of the project to come to a shared understanding of what were the expectations from people in the community. So over to you, Paige.
Yeah, and I guess from what Karen was saying earlier, it was patient-driven research, and so when we first came to the team, that was one of the first things that was brought up that didn't really feel comfortable. And one of the main reasons, I think, was because it created a power dynamic even in the room before we had even gotten started. So we chose the word as a team to use community-based research, and the way we did that was by coming up with project expectations. So the three we came up with are increased awareness, increased dignity, and contribute in a meaningful way to the community. And I know that these words, like increased awareness, dignity, compassion, they all seem like very light words that we use all the time. But I'll explain to you in detail. When we say increased awareness, we know that stigma goes both ways. So as active users, we know that we're not in the best condition when we're in active use compared to when we're not. So we'd like doctors and their assistants to know that we fully understand that, and that stigma can go both ways. And once this has been addressed, then hopefully it'll be more of a topic.
Mm-hmm.
increase dignity. We really wanted to build trusting relationships across the project. You saw that we're working with a wide demographic of people. So we have the Health Authority, we have 2 universities, we have Solid, who's more harm reduction based, and then there's Umbrella, which is abstinence based. So you have quite a wide variety sitting at the table every couple of weeks and trying to go over such a big topic like stigma. So increasing individual dignity to people was a really important one for us while we're sharing experiences. The third one is contribute in a meaningful way to the community. And I think the largest part that we came out of with this was that as addicts, we all felt a bit distraught about how much we had taken from the community, taken from ambulance rides, from service providers, from doctors, just take, and we wanted to feel like we were giving back, giving something positive back, especially in the current opioid epidemic. People are just seeing an increase of health crises. So we wanted to be really forward-thinking and more solution-based thinking and wanting to give back in a meaningful way was through this project.
Okay, so we used a technique called concept mapping. It's a research technique to address our project objective as investigating patient understandings of cultural safety in primary care. So that was the first objective that we had for this project. And so I'm not sure how many people are familiar with concept mapping. It's a set of steps that you go through to illuminate or get some insights on a construct that you might not necessarily be familiar with at the outset. And so, or a concept that hasn't been well articulated in the literature. So for us, our concept of interest was cultural safety in primary care. And so you begin the concept mapping process by identifying a focus prompt, and that's your single question or your single survey item that you use in order to get the conversation started about how people understand and think about cultural safety. So the focus prompt that we came up to was, I would feel safe going to the doctor if. And that was the only question that we asked of participants. We held 3 rounds of focus groups, so we had everybody come in 3 times. In the first focus group, they brainstormed answers or sort of phrases to complete the statement, I would feel safe going to the doctor if. And we ended up with, I think it was 700 different responses over the 75 people that we talked to in the first round of focus groups. We whittled those down to 75 roughly statements, which we had people come back and sort into piles based on how similar they are to one another. So statements that appeared to belong together. Then we did an analysis using a software package called Concept Systems, which sorts the statements into groups based on how often people tended to pair them together. And what it generates is a set of results which tell you about the core themes within your set of statements, both sort of quantitatively and qualitatively. And we brought people back together a third time to show them the results and to just talk about how important the statements were relative to one another to help us name the groups. And so it was an iterative process, and I guess we completed this over, it was probably about a 6-month period where we met and did all of this. And so in between meeting with all of our participants, who were 75 people who all were either actively using or had a history of using substances and had experiences of stigma, and we had them participate in this, and we met, dozens of times outside of those focus groups as well, to just make sure that we were all on track and doing things well. So that's what I went over. So we had groups. The groups, I will say, were led by our community researchers, and we managed to recruit, interestingly, even numbers of males and females, and we had 80% of participants return for the second and third focus groups. So we had a very good response rate. Thanks to our community
I was
research.
going to say, because of our community, we couldn't have done it without the
No.
community researchers. It would have never happened in that time frame.
Yeah.
And to be honest, if it wasn't that strong of a project, I don't think we would have been able to do it either, because to get 75 people who are either currently homeless or in transitional housing, to get them to come back 3 different times with so much space in between should be a lot more difficult than it was.
Mm-hmm.
Yeah. Well, when Paige booked the focus groups and she told me how fast we were going to do them, I was like, I kind of gulped and went, oh my gosh, I don't think I could do them that fast. I said, is it possible? And she said, on this topic? Of course.
Yeah, we had, I must say, it was one of the easier projects that we've ever had to recruit for. It was very, very quick. We had lots of people who wanted to share their experiences with us.
So, Karen, I think we covered this one, the
Yeah.
700 statements.
Just reiterate, taking 700 statements down to 73 was not easy. And so that was basically bringing them down to take out duplicates, just capture 73 unique pieces of information, and because you can't have people sort 700 statements into piles, obviously. So we had to get it down to a reasonable number, and we did. It took a while, but we did.
Mm-hmm. And so here's actually the outcome of that process that Karen just described. As she said, you feed it into a concept mapping systems program, and it gives you a choice of different arrangements of clusters. And so the core research team, which was the community and the academic researchers, we went through all the various kind of iterations, and we chose the 8 clusters that you see here. And between us, we're going to introduce you into each of the 8 clusters that describe what culture-safe primary care means from the perspective of people who use substances. And so here's the first one.
Hey, I'm human, treat me right. Don't turn me away or refuse to provide care for me as a result of my drug use. Treat all patients with respect, compassion, dignity, and human decency. Don't red flag me. Recognize addiction as a health issue. The physician is drug-wise, meaning that they are knowledgeable about and recognize addiction as a health condition and not a criminal issue. They're up to date on treatment, management, and resources. Don't red flag me for my drug use, and instead offer me a range of treatment options, including harm reduction.
And we chose the word red flag, but sometimes it was also described as being blacklisted, purple dotted as well.
Whoops, that one.
Oh, so, no, you, Paige.
Act to prevent stigma. Don't treat me like crap. The care I received is characterized by respect, dignity, sensitivity, empathy, and understanding. I'm not fearful of being judged, labeled, or stigmatized for drug use. Do you care about me? Feeling like the physician hasn't the time and isn't rushing. We have a relationship and a rapport with consistency and care from one provider, which allows for continuity and follow-up. Our relationship is characterized by trust and rapport, and the care provided is holistic.
Live up to professional standards. We put in, our question said doctor, but it was interpreted as any primary care provider, and that's just an important note. So the doctor or primary care provider has up-to-date knowledge of addiction and pain management for people who use drugs. My doctor collaborates and communicates with me to make informed decisions about my treatment, especially with regard to prescribing medications and pain management. And the next one is maintain confidentiality in a welcoming and comfortable environment. And this refers to the environment of the clinic being welcoming, comfortable, non-institutional, to reduce my feelings of vulnerability. People talked about not feeling overcrowded in the waiting room, because people often describe feeling very anxious when they have to wait, and that office policies and protocols are designed to ensure patient information is kept private and confidential. And the one example that I think came up quite often was people being asked in the waiting room, what are you here for? And it's really hard to say what you're here for when it could be something very private. Or someone says, oh, you're here for your HIV test. So now you've just sort of outed people's information. So there's no public sharing of information in the waiting room between staff, and I don't have to wait for an appointment, and appointments and information are accessible.
Acknowledge and accommodate my needs and circumstances. This cluster of statements referred to an approach to care that recognizes the social determinants of health and makes the necessary arrangements to ensure that care is not limited by my circumstances. Patients should not suffer negative repercussions and or harms as a result of their social and economic position in society. Be a champion for advocacy. These statements refer to patients needing to feel supported, to feel safe and secure, to reduce the anxiety they may have about seeking care. These supports extend beyond competencies or characteristics of individual physicians or individual clinics to include environmental supports, such as being allowed to have an advocate come with you to your appointments, as well as the environment outside the clinic, and system supports like adequate insurance coverage.
And I mean, people even talked about being charged for things like appointments.
Right.
Which would be a very simple kind of thing to address.
Mm-hmm.
So those are the 8 clusters that define culturally safe care from the perspective of people who use substances. That was collaborated or generated collaboratively. But we also asked another question, and that was whether or not the SPORE patient engagement framework was adequate to guide culturally safe research with people who use substances. And so we actually did a series of focus groups to also ask the question around what was culturally safe research from the perspective of people who were conducting research. And so here's an example, it's actually 6 points that emerged when we asked that question about what is culturally safe research. And a critical feature is that culturally safe research shifts from thinking about them or those people out there to us as a team. It puts building trust and relationships as a core priority. And so that the research is always about producing knowledge, but it puts that trust at the center of the knowledge production process. It values practical knowledge and lived experience, and that doesn't mean just saying that in words. It means saying that with the way that resources are distributed, things like ensuring that the community researchers are adequately paid at an equivalent rate for their experience. It means ensuring that the way you set up the research team is structured to address power inequities. And you notice how we had the core team and then we had the broader team. That was all done quite deliberately to ensure that the research was community driven in this case. And then I think for us as researchers, and and I'm referring here to academic researchers specifically, I think we have a very important job to do around making those power differences between academic researchers, people who are in the role of community or patients, and other players, organizations in the community. We have to bring awareness to the fact that we all are situated quite differently, and we hold different kinds of views and values, and that sometimes we sort of have to point out, and I wouldn't say it's easy, I'd say it's very hard to point out some of those power inequities that exist as well. And then the last point, and this is probably was emphasized more than any other point, is that the research has to be actionable. There has to be some kind of outcome that produces action. We can't just generate knowledge. There has to be actually some change, because you're, if you're calling them, we call them community researchers, but I know other projects called patient partners. They have put a lot of time and energy and their own resources into doing this work. And so there has to be an actionable outcome and some actual action come out of the research, because the process, has already taken time. And so I'm going to turn it over to Karen, and she's going to talk a little about our knowledge exchange strategy, and then Paige is going to finish up with some comments, some examples of action from this research.
So this is the phase of the work that we're currently in, and we're coming up with different ways of reaching different audiences with this finding. So as you can tell from the clusters, the types of stories that we heard, the types of statements that we heard pertain to not just physicians, but as Bernie mentioned, other primary care providers, ranging to medical office assistants, security, whoever happens to be within the context of the primary care clinics. And so we had multiple audiences that we wanted to reach with this work. We're currently in the process of creating workshops and video, and we're happy to come and share those with you. For anybody, just get in touch with us. But as we embarked upon figuring out how we wanted to share the knowledge from this project, we came up with 4 objectives. And so that's what you see here on this slide, is that in communicating the results of our study, we want to raise awareness of the issues related to stigma and also barriers to primary care that are experienced by people who use substances, and to share those understandings of culturally safe primary care for this population. We want to support the ability of people who use or have used substances in order to advocate for their own primary care. We want to secure the commitment of people who used or have used substances, physicians, health planners, and government to collaborate on strategies to improve cultural safety in primary care. And we want to encourage the participation of the population, as well as physicians and, again, health planners and government, in developing and implementing policies and practices that will improve cultural safety in primary care.
So one of the first products that we developed was this little postcard. I'm going to turn over to Paige to talk about the postcard. Because Paige made this statement about a month ago. She said, "This postcard saves lives." And I said, "What do you mean?"
And I'm racking my brain over which story I'm going to use. I don't know. So this postcard, I guess one of the first really jolting experiences that I had with it was one of our main volunteers. She volunteers in our office 4 to 5 days a week. She's quite a variety of tasks, and she was in the hospital, had a something really big come up, and she left the hospital, rushed back to work just to bring me a big stack of Island Health magazines. And she's all flustered, and she's throwing down her bags and her books, and she opens it up and she said, "Paige, look at this, and she flips through it, and she opened it to an article of our whole team and our postcard on the back, and it's just an explanation on our project. And she said, "Look, this is us, and she wasn't actually in the picture, but she was a participant in the research, so she had remembered it. And she said, "I couldn't just take one, I had to take the whole stack, as many as I could find in the hospital." And she actually had a whole stack with them, and she left me with one. And she took some bus tickets, and she was going back to the hospital with a card and her magazine, so she could show them, like, this really is us. I don't know if we have another moment, but there was another one in the shelter, and the person was palliative, and they needed extra assistance, so they had us come in, And while we were in there, one of the girls came out who's having a really hard time, and she said, you know, I see you guys are in here. How's so-and-so doing? I remember doing this project. Sorry. And I remember doing this project and how important it was to know how it's going or how things are moving along with it. And so when I was able to give her feedback, as like, you know, this is a postcard that we actually came up with from the statements. This is what we're doing, and this is where people are at. She had a full-on breakdown in the front lobby because the things on the back of the card and the things that we talk about on a day-to-day basis, like the card is what we say. And so we were able, and so to show her the further parts, like all the points that are broken down, how it's broken up, she was just overwhelmed with emotion, and it was just really powerful to feel that, and then to bring that home to everyone else who was watching her and wondering what was going on, what she talking about, who's she talking about. So it just created a whole lot of conversation. And the two people that I told you about were able to access care and able to get themselves out of a palliative position, whereas normally we would have just lost those people, and it just would have been 2 more funerals to go to. It's quite relieving to have that and to have those strong people be able to regurgitate the information that we were able to pass on with the research.
Sorry, I'm just taking a breath as we, Paige shared with you a couple of examples, and maybe we can share one more, and maybe I'll start it, and you can finish it. Is someone took a picture of this card because it was on someone's door at the hospital. It was one of Paige's colleagues that she works with, and apparently the person had put it on their door because he was showing what the expectations were for his care while in hospital. And Paige, you want to add to that?
Like, I guess we were just really surprised we were in the hospital to walk by a door to see our postcard on the door. It was taped to the door. So we're thinking, I've got to know that person, right? Or know them through someone or know what's going on. But I didn't really want to knock on the door and because it was a bit rude. So I asked the nurses, you know, what's with the card on the door, if you don't mind me asking, right? And she said, oh, that's one of the patients in here. He really knows his stuff. He knows his rights, you know. And she started telling me some things, and I realized that I knew him from our street college. So he's currently homeless. He's been homeless for a few years now. It's a lot of situations for him. So to hear that he's such a strong self-advocate, even as a completely detached from most things that we have resources to, he still kept the card with him even after all these months, almost a year. And to have the strength when you're in a really, really poor health condition, to be able to put that first and foremost on your door when you can't advocate for yourself. I think it was really moving for me to know that it's gone that far without us having to push it.
Mm-hmm. And so I think what I understood from what, Paige and some other of our community researchers have told us is that people, when they see the card, feel like their experiences are real, and it actually empowers them to continue with their care rather than leave the hospital or leave. The examples we gave you are actually people using it when they're in hospital, but I understand, we've also heard examples of people who are taking it to their primary care providers as well and using it to open a conversation. And I have to say, from a knowledge translation perspective, that is not how I thought knowledge translation was going to work. I'm proven wrong yet again by my community research colleagues, because I kind of thought we do the research, and then we'd like get it out to all the practitioners and all the senior executives, and something would change. But I guess it's exactly, as people have said, that's exactly how patient-oriented research is supposed to work, is then patients will move the change in the system much faster than anyone else ever will. And so it's, been our experience that just this first output has already started. People have been able to use it and produce change because what's on the card resonates with them. It makes sense to people. And that's because it was produced by the community, with the community. So I think that's the end of our presentation. We appreciate you listening, and I think we've got a good 20 minutes for questions. Please. Yeah. So Heather, can I turn the presenter bulb back to you so that I can close my screen, and then we can see if hands and chats and things go up? Thanks.
So the presenter bulb is back with me, and thanks to you three for an excellent presentation. I love hearing the stories and the way you guys share the information from your research experiences. So I'd like to turn it over to our participants. Right now you're muted, so feel free, if you have any questions, to either raise your hand or you can unmute your mic. And again, the chat function is there to send questions so I can read out the questions by the chat. So let us know if you have any questions. While people are thinking, Pat, I was wondering if I could turn it over to you to see if you have any questions or comments.
I don't. I'll just start my video so you can actually see my smiling face. Hi, thank you so much. Our Victoria contingent, it's always such a treat to get to hear you speak about this project. And it's so impactful, so meaningful, and such a great exemplar for those who are embarking on this kind of health research. So thank you again for, I guess, not only presenting, but for doing this work. So really from the BC support unit and from me personally, I really want to thank you, and for taking the time out of your very busy days, all of you, to help us understand your project and maybe get some creative juices flowing for other researchers, not only in real time, who might be tuning into this right now, but those who might watch the recording later on and think about how the lessons you've learned and the ways that you've proceeded might benefit their project. So thanks again.
Thanks, Pat, and thanks to the BC Support Unit for really promoting this work and supporting us to share with others. We really appreciate it. Thank you. Here's a question. It's from Jenny, and she's saying, so what's next for the team? It's, well, do you want to talk about our Michael Smith read? Thanks to Michael Smith.
We have a bit more funding from the Michael Smith Foundation, and which is amazing. They're going to help us do a couple of things. We reconvened. In fact, we have a meeting today after this to get the group back together to talk about creating a workshop for primary care physicians, or primary care teams, really. So as the primary care networks and are being developed, and there's lots of interest right now across BC about how to reform primary care. We know that addiction health are high up on the priority list for primary health care right now, and so we're preparing a workshop. We've been invited to go on the road and do a bit of a tour, do a workshop with physicians, nurses, and other staff of clinics to talk about the findings and to work through ways in which, or to help providers think through ways in which they are and are not supporting cultural safety according to how it's been described in the first phase of the research. So to really think through some of the specific aspects of practices and how those do and do not make people feel safe, and how we might go about shifting things a little bit. It's often very small things that need to change to just make all that difference for folks to keep them happy and coming back. We're going to go video for that workshop, so that's pretty exciting because we get to think about ways to do that. What else are we up to these days?
I think there's probably one thing that I would kind of add is that sometimes when providers particularly look at our findings, I often find there's two kind of reactions. One reaction is, well, that's kind of basic and it's kind of obvious. And what's interesting about that reaction is that, I'm a registered nurse, so I see it through the perspective of a healthcare practitioner, is that it is, you know, if you have something that says like live up to professional standards as an example, we all strive to live to those professional standards every day. But I think the part that is so profound is that when we are working in a context where drug use is so highly stigmatized because of our current drug laws, what is basic actually sometimes becomes kind of lost, because practitioners are no different than anyone else in society in terms of taking up stigma and doing it. And so I think my first clue in the project was, and I don't know if Paige will remember this, but Paige and I did a lot of focus groups together, and then Karen and a couple of the other community researchers, they did focus groups together. But in one of our focus groups, I think it was the second round, one of the guys came back and he had just been at the hospital, and he said, I told them that I'm in the cultural safety and healthcare project. He said, I know that this is about primary care, but I told him about it. It was about hospital care because I thought it applied there too. And I think that was kind of my first clue of how important this topic was to people when, for real and perceived reasons, it is really challenging to access healthcare on a daily basis, and people do not make those decisions easily or lightly. We just had an example someone brought up in our own team a couple of weeks ago and said, you know, they were going to the healthcare provider and they spent 20 minutes thinking about what they were going to answer when the person said to them, what are you here for? You know, thinking about how to do it, even though it probably was fairly benign. So it's just I guess, you know, when I hear that kind of reaction, I think, yeah, it is basic stuff, but we really need to reflect on deeply about how are we doing kind of those kinds of basic things. The other reaction we sometimes get is, we don't do that, and then we have another talk about, okay. And I don't think every provider does do it. I mean, I don't think this is about, this is not about bad providers. This is about how the system sets some things up differently for some people than others. And, you know, I'm a registered nurse. I've worked in this profession for a long, long time and in this area for more than a decade. And I can look back and say, you know, I have to, even though I may feel like I haven't done anything, I still have to look and say, what is the health system? How does the health system contribute to this at the same time? Here's a good question from Alana. How were appropriate salaries and stipends determined for patient researchers and focus group members? Good question. Do you tell the story?
You can tell the story.
Yeah.
Oh, God.
I just gestures.
It's funny need to see Bernie do the hand actions.
I don't know if I can. I'll try.
Try.
I'll try. You guys will help me. We wanted to pay people equitably.
Yeah.
And one of our community researchers, Jack, said at one point that his education cost him $6 million of heroin in his arm, and so it was an expensive education. And then he said, and so, you know, Bernie Polly, how much do you make, and what makes you feel, you know, what do you feel you're being adequately rewarded? And I said, yes. And he said, well, that's exactly what I want for the community researchers as well. So we determined that an equitable rate would be the same as what a graduate student makes as an hourly rate, and we use that rate both for the community researchers and for the focus group participants.
Mm-hmm. You can see we've got a few questions coming in. I know there was a question before about how we're, oh, sorry?
Yeah, you're right. There was just a couple above. I don't want to get them missed, so scroll up a bit. Okay.
Yeah.
Okay.
Oh, how can someone get a copy of the postcard? So we do have a website for this project, and it's on CSER's home site. You just look for Stigma in Primary Care under ongoing projects. We have copies of what we're going to do is we're going to post a printable copy of the postcard so people can print off their own. But if you would like some hard copies printed on photo paper, just give us an email and we can get you some copies if you'd like to display them or share them around your own networks. Just let us know. You can email Bernie or I, and we'll get them to you. How were core group patients selected? So our research core team, our community researchers, were people who had interest in participating in the development of a research project. So I guess that's self-selection. The people who participated in the focus groups were people that the community researchers recruited, and so they were from their own networks. And what we did, the only stipulation we had on that was what we wanted a bit of a, we did some purposeful sampling to make sure we had relatively equal numbers of men and women, that we were getting fairly similar, I guess, in terms of people who were recruited through the harm reduction service and people who were recruited through more of an abstinence-based group service. And so we varied our settings and who was doing the recruiting in order to make that happen. It wasn't meant to be a representative sample. It was meant to be a purposeful sample of people in Victoria who could speak to the issue.
And what Karen mentioned that's kind of important is it was people with a broad range of experience of substance use, because we recruited both through a harm reduction organization and abstinence-based organization.
Which was, again, purposeful to see how things, and it's really funny, the statements didn't differ. We did look to see if we were getting different types of information from the two groups, and it really wasn't. Not really.
There's a question about actually doing the concept mapping. Who was in the core team? How many were academics? How many people were lived experience? And who was actually working together to go through the statements and create the clusters? Okay, yeah. So the core team was Karen and I, along with one other academic researcher from Royal Roads. And then there were 3 members of Solid who were community researchers, 3 members of Umbrella. So there were 6 community researchers and 3 academic researchers.
Yeah.
So we, together, the 9 of us, crafted the focus prompt. We did all the data collection. So the way we did the data collection is I worked with the 3 community researchers from Solid, and you set up all your focus groups, and then I went to all of the Solid focus groups. Karen did the same for Umbrella, and in the actual focus groups where we were doing the brainstorming the first time, and then the sorting and rating and all of that, those were facilitated by the community researcher. So Paige still laughs at me because she did all the facilitating and I did all the note-taking.
Yeah.
700 statements of note-taking. I kept up with them all, so.
Yeah. I guess a couple of things I'd add to that is that in the initial meetings when we were getting together to plan the project, we had we went through some online modules of what it means to be a researcher instead of a research participant. We looked at research ethics, different topics, research process, so that we would all be on the same page as we got started.
What is concept mapping?
Yeah, what is concept mapping? We did a video of one of our community researchers did a video with the help of our researcher from Royal Roads to have himself reading out the consent form, so that we could watch the video at the beginning of our focus groups, and then just use that to start a discussion with the participants to make sure they consented to us, to participating in the study and us using their information. So it kind of helped, I think, to reduce the pressure of that part of the research, which is sort of very important at the front end of making sure that everybody knows what the study's about, and that you're not sort of forgetting to say things that you need to say in order to get people informed about the study.
And I was kind of thinking when Bernie first brought the project to Solid, she brought, I'm not entirely sure how the Umbrella Boys got chose, but whenever research comes to Solid, it goes to our board of directors, and our board of directors has to approve of the project, and then from there they would nominate people, or some people would step up. When this project first came up, we turned it down twice, and we accepted it on the 3rd time. And the reason I'm telling you this story was because of what the girls had just talked about, us being involved from the beginning before we started, when we actually got started, being involved through the whole process, concept mapping, which we didn't know anything about, taking the results back to the streets as we're getting the information back and forth to the researchers, bringing the relationships that we brought from the research, from like meeting the whole research team, bringing that back to the streets, and then bringing the results, the postcard, back to the streets as we got it. And having that involvement from the beginning to the end, and I think what was pretty huge for our team and why it was such a big community project.
Yeah. Yeah, it struck me about how important it was throughout that we had that mechanism for reporting back and forth to each other, so that you guys were able to know that you had influence on the project. Like you were on the research team. You had influence over what was going to happen and how things were going, and that was very important. Yeah.
And I think one of the other community researchers, I think the way he put it is Karen and I think what he said is Karen and I, you guys are kind of in charge of the science, to make sure that we're following the ethics protocols and the concept mapping, but he said you can never have the lived experience and the social networks and the knowledge that we have, but you can sort of help us with that other part. I think that's kind of how it was positioned in this project.
Mm-hmm.
Saying very helpful to hear what was most important for Solid to approve. Yeah. Mm-hmm. And it's interesting because organizations should have their own expectations about what kind of research they're going to participate in.
Yeah, working in partners is really important, having someone beside you, and that just helps show how tokenism treats people if you're always using one peer for everything, or if that peer doesn't have proper support, so if you're not using a wide enough diversity. So I think that was really important for us.
Mm-hmm. It's huge.
Up there with pay equity.
Yep.
Yes, that was a huge issue as well.
Okay. Great, thanks for the questions from the participants and from the presentation team. Does anyone, about a couple minutes left, does anyone have any other questions or any other final thoughts or comments? Wrap things up. Okay.
Okay.
I will take that silence as thanks to you guys very much, and for everyone joining us online.
Great.
Thank you.
Thank you. Bye, everybody.